Hello, my name is James, and in today's lecture video, I will discuss acid-base balance. So join me throughout and let's simplify this topic using relatable analogies and visuals to make the science of acid-base balance as easy to understand as balance in a checkbook. Do well to subscribe and let's get started. So the normal pH range of a human body is carefully maintained between 7.35 and 7.45. Okay, reflecting a delicate balance of acidity and alkalinity. So when pH drops below 7.35, the body enters a state of acidosis, indicating an increase in acidity that can disrupt normal physiological functions. Conversely, a pH level rising above 7.45 signals alkalosis, also suggesting a decrease in acidity that may also lead to an imbalance. So, it is very essential for the body's pH to remain within optimal range to ensure overall physiological functions. All right, so we're not going to waste time in the interpretation. Our first step is to evaluate the pH levels. If the pH levels are decreased beyond normal range, we are facing acidosis. If the pH levels are increased beyond normal range, we are facing alkalosis. The next step is to determine the origin of the disorder. For this purpose, we're going to need the carbon dioxide levels. So let's just say after checking the pH, we have acidosis, and then we proceed to check the carbon dioxide levels. If this is increased, then we are most likely dealing with a respiratory acidosis. Let's just say after assessing the pH, we had alkalosis. We proceed to check the carbon dioxide levels, and if it is decreased, then we are most likely dealing with a respiratory alkalosis. A recap. So a pH level which is decreased, carbon dioxide levels which is increased, is most likely a respiratory acidosis. If we have pH levels which increases and then we have carbon dioxide levels decreasing, this is most likely respiratory alkalosis. Okay, so what I have described here, all this aligns with respiratory disorders being the primary cause. So let's just say that the findings don't align with the respiratory pattern I have just described with this. If it doesn't align like this, then you would have to pivot to consider metabolic factors by assessing the bicarbonate levels. Okay, and so if we check the bicarbonates and we see that the bicarbonate levels have declined, then this is most likely a metabolic acidosis. Because think for a second, you have acidosis. Bicarbonates are there to buffer, okay, to dilute the acid. So if you have acidosis, then most likely the buffer is reduced. And so you will see a decline in the bicarbonate levels. Let's say the bicarbonate levels are rather increased. Then this would explain that this is a metabolic alkalosis. Okay, if the patient has metabolic acidosis, then we would also determine the anion gap. I will explain that further, okay? And again, if it is metabolic alkalosis, then we would have to assess if it is responsive to chlorides or not. Yep, you got it spot on. The straightforward relationship is that in respiratory acidosis, the pH levels are decreased, but the carbon dioxide levels are increased. In contrast, in respiratory alkalosis, the pH levels are increased, but the carbon dioxide levels are rather decreased. Okay, you can also think of the first three letters of the word acidosis. So A stands for acidosis, C stands for carbon dioxide, and I stands for an increase, which means we have a respiratory acidosis. You can also look at this side for alkalosis. The A stands for alkalosis, L stands for low, and K, you can replace this with a C, which would mean a low carbon dioxide. Okay, now there is something important that I want you to know. If you realize any change in the bicarbonate levels alongside this expected pattern for respiratory disorders, this would mean a compensation. Let me explain. So on this side, we have a respiratory acidosis. Then you check and then you find out that the bicarbonate levels have actually increased. Or on the other side, let's say we have a respiratory alkalosis. And then we check and find out that the bicarbonate levels have decreased. So what is this supposed to mean? Why is there a change in the bicarbonate levels? This is actually indicating a compensation. So you have a respiratory acidosis, and the kidneys are trying to increase the bicarbonate levels to compensate. Or on the other side, you have a respiratory alkalosis, and the kidneys are trying to lose the bicarbonates to compensate. So this is a metabolic renal compensation when you see this. If the bicarbonates remain normal, this is just a simple respiratory acidosis or alkalosis. All right. Let me use two scenarios here. First, consider a patient with COPD experiencing shortness of breath due to excessive carbon dioxide retention from type 2 respiratory failure. Question: what type of acid-base balance impairment is most likely? So I guess you're thinking of a respiratory acidosis with a possible metabolic compensation from the kidneys, right? Now consider another patient with a severe anxiety who suddenly starts to hyperventilate during a panic attack. Okay, what type of impairment is expected? Certainly, hyperventilation increases the oxygen intake while depleting the carbon dioxide levels, resulting in a respiratory alkalosis. In metabolic acidosis, the pH levels decreases and the bicarbonate levels also decreases. Everything decreases. In metabolic alkalosis, the pH levels would increase and the bicarbonate levels would also increase. Let's just say that you find a change in the carbon dioxide levels. This would suggest a compensation. For example, metabolic acidosis seen with a drop in the carbon dioxide levels. What is this supposed to mean? This drop can be seen as the body's attempt to compensate through the increased rapid breathing. Carbon dioxide is acid, so the rapid deep breathing can increase some intake of oxygen and decrease the carbon dioxide levels, which is very typical of diabetic ketoacidosis and a certain breathing pattern we call Kussmaul's breathing pattern, which is deep and rapid. This is a respiratory compensation because of a metabolic acidosis. Again, in metabolic acidosis, it can actually be an anion gap or a non-anion gap metabolic acidosis. Regarding alkalosis, we have to assess if it responds to chlorides or if it does not respond to chlorides. Now, I would like to take a moment to introduce the significance of anion gap and its relevance in clinical assessment. But first, let's observe this specimen bottle right here, which contains a sample collected for acid-base balance analysis. Within this tube, okay, we will measure levels of certain key cations such as sodiums and anions such as chlorides and bicarbonates. Okay, typically the measured cations are more than the anions. It's important to say that these specific ions, by that I mean sodiums, chlorides, and bicarbonates, are typically in higher concentrations, though. But this does not encompass all the possible cations and anions present in the body. Okay, that means that there is also in this test tube unmeasured anions as well as unmeasured cations. So what we can say is that for a proper electroneutrality, the sum of the measured cations must be exactly the same as the sum of the unmeasured anions. Okay, and this is very important, illustrating a fundamental principle of physiological chemistry. Now let us move to the next slide for more in-depth discussion of anion gap. All right, so the anion gap is a calculated value that represents the difference between the total concentration of measured cations, in this case that is sodiums, and the total concentration of the measured anions, in this case this is chlorides and bicarbonates in the blood. Okay, so typically the concentration of the measured cations are more than that of the anions, and this results in a normal anion gap range of 8 to about 12 milli equivalents per liter. Okay, so looking at the illustration here, we see that this is the measured cations right here. And this is the level of the measured anions. So if we subtract, then we get this anion gap right there. Okay, so this is the anion gap. And the important thing that I want you to know is this part here, the unmeasured anions. Okay, so what are some examples of unmeasured anions? For example, lactate. Okay, for example, ketones. For example, urea. All these substances would increase the unmeasured anions, which will shift these unmeasured anions to this part here. So that if the unmeasured anions increases, then you are actually widening the anion gap. Okay, so if a patient has sepsis or any anaerobic processes, lactate increases. Lactate is an anion. Ketones are also anions, which increases urea and certain types of alcohols. All these can widen the anion gap, as a matter of fact, because they increase the unmeasured anions right there. So a gap which is wider than 20 milli equivalents, okay, is considered an anion gap acidosis. So non-anion gap acidosis can arise from various conditions, one notable cause being diarrhea, which results from loss of bicarbonates from the body. This loss can also occur through direct mechanisms such as fistula connecting, say, the colon and the bladder, for example, mirroring also the bicarbonate loss seen in ileostomy as well. And also renal failure and renal tubular acidosis are also potential contributors to non-anion gap acidosis. Metabolic alkalosis. So we're going to take a look at renal hypoperfusion. There is going to be an increase in renin that leads to an increase in the secretion of aldosterone. This would also increase the sodium water retention because of more reabsorption of sodiums, and this comes with more reabsorption of bicarbonates as well, and this would lead to a metabolic alkalosis. Loss of gastric fluids. If you lose fluids from the stomach, you are actually losing acid. Okay, you will lose the acid, and so you will certainly become alkalotic. These are two typical examples of a chloride responsive metabolic alkalosis, in which case the chloride levels in the urine are usually less than 20 milliequivalents per liter. Such types of metabolic alkalosis would respond to a normal saline. Let's also take a look at chloride unresponsive metabolic alkalosis. So we are looking at a situation where the urine chlorides are more than 20 milliequivalents per liter. And an example is a disruption of potassium metabolism, which leads to hypokalemic states. Examples may include primary hyperaldosteronism, Bartter syndrome, Cushing's syndrome, and also normally when potassiums decrease, they might decrease with the magnesium. And so a low magnesium state might also lead to a chloride unresponsive metabolic alkalosis. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.